Hi, Dr. Gullberg here, continuing our infectious disease series. Today we're talking about Candida infections, as well as Candida problems in the immunosuppressed host. So Candida infections, very most common dimorphic fungus that we deal with clinically, no question about it. Got to know a lot about it. So Candida in general, 60% of the strains are going to be Candida albicans, generally very sensitive to imidazoles like fluconazole. But there's other Candida species that you got to be aware of. Torulopsis glabrata, 15% of the species used to be called Candida glabrata, now Torulopsis because it tends to be resistant to fluconazole. Also, there's Candida parapsilus, Candida tropicalis, Candida krusei, and Candida lusitaniae, which tend to be those latter tend to be resistant even to amphotericin B. So the most common Candida infection we see, of course, is thrush, usually seen in the immunosuppressed host. Somebody who's on steroids, maybe they've got HIV infection or some kind of a cancer, they're on chemotherapy. But they can be diabetics and just be suppressed for other reasons. Treatment of choice, of course, is nystatin, swish, and swallow, or Miscellax troches 4 times a day for 10 days. Usually takes care of the problem. Once Candida gets into the esophagus, there's a lot of difficulty swallowing and a kind of a frothy cottage cheese discharge. These people need fluconazole, 200 milligrams a day, or itraconazole for 7 to 14 days. Usually respond very well. And then, of course, Candida vaginitis is a big issue, especially in pregnancy, diabetics, women on getting antibiotics. Intense pruritus, curd-like discharge. Treatment of choice is topical azole creams or fluconazole. Again, people respond very well. Urinary tract infections from Candida are possible, especially if their patients are diabetic, if they've got a catheter in, if they've got hardware, if they've got a kidney stone. Any abnormal anatomy makes this a very difficult problem. Sometimes there's colonization, but generally it's going to be a difficult to treat infection. Make sure they don't have kidney disease. Usually fluconazole is helpful for Candida albicans or lipophilic amphotericin B. We use 0.3 milligrams per kilogram times 1 dose. Getting rid of the Foley catheter, the obstruction, or the stone is the most important thing, however, for Candida urinary tract infections. Now, we see Candida in the bloodstream, fungemia. That's really big trouble. Usually associated with nosocomial disease, central lines, immunosuppressed patients on antibiotics. It causes 8% of all nosocomial bloodstream infections, and of course, it's increased risk in neutropenics, people on TPN, people on chemo. People who've had GI surgery, if they've been in the ICU for a while, or of course, if they've got a bone marrow transplant. Remove the line, keep them on antifungals for at least 10 to 14 days because they can get metastatic disease even in the retina or the eye. So watch for that. In terms of our immunocompromised hosts, people who have cancer, look for invasive disease from Candida. Can get into the lung at times, can get into the liver, skin, ocular, I already mentioned, endocarditis with big vegetations, and of course recurrent fungemia. So our neutropenic fever patients who are immunosuppressed because they're getting chemo, these people are often on oral azole antibiotics, but they have an increased rate of fungal invasive disease if they've had fever for more than 6 to 7 days. So those people often will end up on IV antifungal agents such as micafungin or voriconazole or even amphotericin B. So good summary of Candida infections and what you need to be aware of. Thanks, Dr. Gullberg signing off.